Hey, everybody, this is Greg Lake with the TheoConnect.com coming at you with a special podcast today with Dr. Ben Malcolm, who is a doctorate in pharmacology, who works with Chacruna's medical team, I guess I would say, who has been conducting some research as of late regarding potential contraindications or dangers associated with mixing certain psychiatric medications with this particular study, psilocybin and or MDMA. Dr. Ben, thank you for coming here today. Thank you.
Thank you, Greg. It's wonderful to be here with EntheoConnect.
Yeah, thank you. So I guess we'll just jump right in. And I came to this because I read an article. I was surfing social media a few days ago and saw where y'all had actually gone back through some of the trials and other case studies dating back quite some time to look at, I guess, the possible, again, contraindications or dangers associated with mixing certain psychiatric medications with either psilocybin or MDMA.
Yeah, that's right. So there's been not that many studies, to be honest, that have sort of directly looked at drug-drug interactions. And I kind of reviewed a lot of them previously, but there was a psychiatrist, or he was in the very last stages of his psychiatry residency, Dr. Orion Sarparist, and he wanted to do a systematic review, which is essentially you create a structured set of methods that you search the literature with, and then report on the results. So we were looking for studies that dealt with either MDMA or psilocybin that had a direct drug-drug interaction, like they are combining two substances in, the same sort of time period or session, rather than kind of, oh, we did one and then, a few weeks later we did another one. So actual drug-drug interactions. And yeah, looking particularly at MDMA, psilocybin, and then as many of the psychiatric medications as we could possibly think of. And we use sort of an international manual to really try to get as many of them as we possibly could. And that was the kind of methods anyway.
And when I read the article, it's kind of split into two, I guess, entheogen psychedelics. It would be MDMA and psilocybin, but then on the other end looked at like SSRIs, MAOIs, and then I saw some information on lithium there. Is that correct?
Yeah, so MDMA or psilocybin just broadly with psychiatric medications. And really that could be, we got the most hits, right? Literature hits on like SSRI antidepressants, antipsychotic types of medications. But yeah, like we were looking for lithium, mood stabilizers, stimulants, benzodiazepines, like the whole kind of gamut, sleep aids. Yeah. Yeah.
So I guess let's start with kind of SSRIs, because those are probably the most well-known and probably the most prescribed. What kind of results did y'all see as far as SSRIs in these substances?
Yeah. So for MDMA and SSRIs, because MDMA has a rather complicated kind of mechanism of action overall, there's actually been a number of pretty elegant studies that have been done over a couple of decades looking at different medications that could potentially block some part of MDMA's mechanism of action, to try to determine, where is the lion's share of MDMA's effect coming from. And these experiments with SSRIs have really kind of pinpointed that MDMA does quite a few things. It releases norepinephrine, dopamine, serotonin. It releases, it has like neurohormonal properties, like release of oxytocin as well as vasopressin, and it stimulates serotonin receptors. So it's kind of like what part of that? And it really seems from the studies with SSRIs is that the release of serotonin is critical to MDMA's mechanism of action, because every time they pre-treat someone with an SSRI and then give them MDMA, the effects of MDMA, the subjective effects, and some of the physiological effects too are diminished somewhere between 40 and 70%. So with SSRIs and SNRIs as well, there's a couple other medications that are really closely related to the SSRIs out there. Seen with MDMA, they greatly diminish the subjective effects and some of the physiological effects as well. With psilocybin, there's actually a lot less data out there, maybe because psilocybin has a simpler mechanism of action overall. It just stimulates serotonin receptors. But there were really, at least the time that we did this systematic review, our literature search, there really were no formal studies between SSRI or SNRI antidepressants and psilocybin. And anecdotally, it seems much more of a mixed bag, with some people reporting effects while taking SSRIs or SNRIs, and some people reporting that the effects are somewhat diminished, some people reporting that the effects are almost entirely muted. So that one is a little bit more of an open-ended question. There's been one drug-drug interaction study that's been done with escitalopram or Lexapro, which is an SSRI, and psilocybin since then. And they found that some of the negative aspects of the psilocybin experience were diminished, but they didn't really find a reduction of the positive effects of psilocybin. But the major problem or flaw with this study is that they only use Lexapro for 2 weeks, where it's very well known that antidepressants like SSRIs or SNRIs take at least 4 weeks, and maybe even more like 6 to 8 weeks, to really produce the sort of neuroadaptive changes that might be linked with improvement. But those changes are probably also linked with reduction in serotonin receptors, which at least hypothetically could reduce the effects of psilocybin. So with MDMA, it's fairly clear that the effects seem diminished. There's much more of a pharmacologic rationale for a direct drug-drug interaction. Psilocybin, it's a lot less clear, and there's a lot less information available.
So when I first started in this space, there was a lot of talk about serotonin syndrome. And back then, this was maybe 2-3 years ago, the big thing was like a lot of people were real hardcore about, this, even psilocybin SSRIs can cause serotonin syndrome. Do not do this, And so it seems like the data is kind of coming out that isn't as much of a concern as maybe it was at one time. Or what are your thoughts on that?
Yeah, so I do think that the data is confirming that serotonin toxicity or serotonin syndrome is not likely to occur with therapeutic doses of SSRIs and psilocybin or MDMA. Psilocybin in particular is a substance that is known to have an incredible physical safety profile. There's very, very few psychoactive substances that you can survive a 10-fold, 50-fold, maybe even 100-fold overdose of. And psilocybin is one of those. And when you kind of look at toxicology reports, like, okay, mushroom poisoning cases, adverse effects, going to poison control centers, usually it's a 20-year-old male that is coming into the emergency department experiencing some type of problem with psilocybin mushrooms. The rates of adverse effects are incredibly low in the adult general population. So serotonin toxicity or serotonin syndrome is rare, even with substances that could cause those types of things. And I personally haven't really found much in the way of convincing cases with psilocybin or mushrooms. MDMA, I think, is a little bit trickier in that the SSRIs or SNRIs maybe block the serotonergic effects of MDMA. But at least an SSRI probably would not block the noradrenergic or dopaminergic effects of MDMA. So it's sort of like, okay, maybe it inhibits some of the serotonin release, but it's not going to do much for the dopamine or norepinephrine release. And some antidepressants have been associated with increased risks of mortality in more like nightlife or types of settings. So I kind of suspect that for some persons, their night kind of goes like, oh, I was taking my antidepressant and, we all took ecstasy with our friends, and an hour and a half later, they were having a wonderful time. I wasn't feeling anything. So I decided to take another one. And then 45 minutes later, I wasn't feeling anything. So I decided to take another one. An hour later, I was experiencing some type of stimulant toxicity. So I think that sometimes with MDMA, because it doesn't have the same type of safety profile and overdose that psilocybin has, that the blunting or muting effects of antidepressants could actually, I don't know, it inspires the wrong word, but cause someone to take massive doses of MDMA or ecstasy trying to overcome these effects. And either because of the stimulant effects of MDMA or perhaps other adulterants that are in there, or maybe other substances that you're using to try to potentiate or get themselves having an MDMA experience, that maybe there is some type of risk of something bad happening in certain types of situations there. But I'm thinking clinically, when the MDMA is pure, the dose is moderate, what dose of SSRI things people are taking, I don't feel that there is a huge risk of serotonin toxicity.
Yeah. And so also I read in there, and this might have just been one case that y'all found, but I see where there was a potentially dangerous combination with lithium and psilocybin.
Yeah. Yeah. So lithium, I would say, is the exception to the rule. Like of everything I was just saying about, well, psilocybin, I would include LSD in these conversation. We didn't do the
Okay.
systematic review on LSD, but for a lot of intents and purpose, physiologically, the safety profiles of psilocybin and LSD are fairly similar. So with lithium, it's interesting because it's not a drug, really. It's not a small molecule. It's an element on the periodic table. The body tends to handle it similarly to sodium. We're not exactly sure how it works mechanistically as a treatment for mental health, but it probably does something to change the intracellular signaling cascades.
Okay.
So there might be something where psilocybin is binding to the serotonin receptor as usual, but the signaling responses to its binding are changed. And it seems that it's changed less towards a psychedelic and hallucinogenic experience and more towards a physiologically challenging / toxic type of experience. So there's been some cases where people report seizures with lithium and psilocybin or MDMA or LSD, right? Serotonergic psychedelics in general and lithium have been flagged to either cause seizures and adverse effect or just have a challenging or negative kind of experience. Like the negative quality of the experience seems to be more predominant than with other medications. And there's one specific article I'm thinking of that compared classic psychedelic experiences from Arrowwood between lithium and lamotrigine. And there was big differences between sort of the anecdotal reports between the kind of combinations. So lithium is kind of the exception to the rule, really. Like I feel that psilocybin is pretty safe with just about any other substance except for lithium because it's a chemical element. It's not a drug. It changes the signaling cascades and it does something that seems to increase risks.
Wow. Okay. Yeah, that was I've always said it's just been my general belief that psilocybin is pretty relatively safe, but it's good to know about this lithium thing because there are quite a few people out here on lithium, and so that should be one of those things that for people. And again, I deal with a lot of religious practitioners, but people who are screening for ceremony, that should be a big red flag, right? The lithium.
Yeah, I would say so. And I mean, lithium's kind of a double red flag if you're thinking about screening for
Okay.
psychedelics, really, because lithium is a medication that's indicated in a mood stabilizer, usually for bipolar types of conditions, which is something that can also increase the
Yeah.
risks of using psychedelics. So it's almost like a right. It's like, okay, you're taking lithium, that can increase the risks of using psychedelics, but then tapering or stopping lithium is probably going to increase the risks of decompensating whatever condition that we're treating. And if it's a bipolar condition, then well, that seems that, for most intents and purposes, people are considering particularly bipolar 1 conditions to be contraindicated from psychedelic use. And now you've got someone with that very condition that's not really on a stabilizing kind of medication, and it probably opens the door for some, poor outcomes to occur.
Wow.
Yeah.
Cool. Yeah, appreciate that info. And then kind of the last little part of the article discuss MDMA and MAOIs was
Yeah.
potentially dangerous.
Yeah. So with the serotonin toxicity thing, there's a lot of myth out there. Serotonin syndrome, serotonin toxicity. I prefer the term serotonin toxicity, but there's a lot of other sources out there that are saying serotonin syndrome. But with serotonin toxicity, there's a lot of myth out there where it's kind of like any drug that works on serotonin can cause serotonin toxicity.
Yeah.
But serotonin toxicity is a form of poisoning, and it's a form of poisoning linked with excessive serotonin in the synapse, which results in excessive postsynaptic signaling. So you have to have drugs that increase serotonin in the synapse to cause serotonin toxicity, right? The other things like the ondansetron, the antiemetic agent that just blocks some type of it cannot increase intrasynaptic serotonin. It seems extremely unlikely that it could be implicated as causal to serotonin toxicities. So there's precisely three classes of drugs that increase intrasynaptic serotonin. One of them is SSRIs, or serotonin reuptake inhibitors generally. One of them is things like MDMA, serotonin releasing agents. And the third is monoamine oxidase inhibitors, which block the breakdown of serotonin, right? So you've got MDMA releasing serotonin, putting more serotonin into the synapse, and you've got MAOIs, which are blocking the ability of serotonin to leave the synapse. So it's really sort of a double whammy that drastically increases serotonin concentrations. And that combination of MAOIs and MDMA might be the highest risk combination of getting serotonin toxicity out there. It's probably higher than even an SSRI plus an MAOI. Whereas the other case that we talked about earlier, MDMA and SSRIs, it's like, well, they both increase intrasynaptic serotonin, so they should cause serotonin toxicity, right? Not necessarily, because the SSRI blocks MDMA's ability to release serotonin. So independently, they raise intrasynaptic serotonin, but together it seems that SSRI really mutes or limits the ability of the MDMA to release serotonin. So that particular combination doesn't seem to have the same kind of risks. But SSRIs or serotonin releasing agents like MDMA with monoamine oxidase inhibitors is about as strict as the contraindications get, really.
Oh, wow. Okay.
Yeah. I mean, I kind of think of contraindication as like there's absolute, like black and white, like just don't ever do it, right? And then there's sort of more relative contraindications where it's like that's a red flag. We probably shouldn't proceed the way it is, but maybe there's some things that could be done to make it safer to proceed. Yeah.
Do you have any gauge on, so for instance, and this is just a hypothetical, let me know if it's well out of balance, but how long would you say, let's say if someone took MDMA on a Monday night, how long do you think it would take to, and just again, I know it's a case by case, but what would generally be the timeline to clear out before it would be safe to maybe engage with an MAOI?
Oh, with MDMA, probably 24 hours.
Okay.
Yeah. Yeah. Because I mean, MDMA releases serotonin. It gets metabolized to MDA, which also releases some serotonin. But by 24 hours, there's not much in the way of serotonin release occurring anymore. The person is usually feeling well and truly down from their experience by that point.
Yeah. Okay. So and again, I know we spoke about this right before it, but kind of my thing here is, I deal with a lot of people who hold religious ceremony, and a lot of this kind of goes to, and I guess specifically with psilocybin, I do know there's people that use MDMA religiously and all that, but really it's kind of geared towards psilocybin because that's the most well known. And so that's why I was kind of, doing this podcast, because I just wanted to relate, some findings that have been found, because there were I feel some misnomers in the space, like I said earlier, about the serotonin syndrome relating to psilocybin. But I guess the moral of the story here is just lithium, no lithium.
Yeah. Well, sometimes you may come across people that are taking, so there's lithium carbonate and lithium citrate that are prescriptions, usually for bipolar conditions, sometimes for treatment-resistant depression, though. And then you have lithium orotate as like an over-the-counter supplement. And the dose of lithium and lithium orotate is at least one, but probably two orders of magnitude lower than the prescription variety. So sometimes I get questions like, hi, I'm taking lithium orotate as a supplement. Are psychedelics strictly contraindicated for me? And the answer is no. You could probably combine them straight up, but if you want to be extra safe, you could stop your supplement for 48 hours around the time of use. And so lithium orotate as a supplement, a lot less of a concern. Prescription lithium, you're thinking, wow, that's dangerous. And what about the underlying condition?
Yeah. The double red flag.
Yeah.
And one more thing, in a lot of this, and I think you mentioned it, but just to reiterate, these were kind of limited, these studies, in the sense that the subjects here hadn't had enough, like really enough time, you feel, to have these medications completely absorbed into their system or have their blood plasma levels of such a degree, especially on the blunting side of the analysis, to really gauge that per se?
That's right. Like a lot of these studies are done in healthy volunteers
Mm-hmm.
where they pre-treat them with an SSRI for a couple of doses up to maybe a couple weeks worth, as I mentioned with the psilocybin study, right? So there's some left to be desired here, right? It's kind of
Yeah.
like, okay, these medications cause differences in effects when you take them for weeks or months versus a few days. You
Mm-hmm.
know, are the effects different if you have someone with severe depression or PTSD versus a healthy volunteer, right? So there's definitely some massive holes in
Yeah.
the literature.
Yeah.
I think that like that's maybe a finding that we haven't communicated from the systematic review yet is like we did a systematic review and found very little about either. I think is almost like the headline, right? It's like
Yeah.
there's
Yeah.
more
Yeah.
with MDMA than psilocybin, but really like this space between psychiatric medications and psychedelics is a huge gray area,
Mm-hmm.
right? That we have very little information about overall. Yeah.
And I think at the beginning of the article, it even stated that I guess the usual course in the clinical trials, anyways, is to actually bring people off these medications before they sit for the trial.
Right,
Okay.
right. So that's something I wish I had like better information about actually from
Mm-hmm.
the trials is because they're selecting people with treatment resistant depression, treatment resistant PTSD, which means that they've failed at least two trials of a first line therapy, which is usually one of those SSRI or SNRI antidepressants. But that's
Mm-hmm.
not incredibly difficult to do. Many,
Yeah.
many people, don't get the response they're after one or two trials with these types of medications. And, some people with treatment resistant depression are going to say, medications just don't work for me, and they're not going to be taking them. So I actually think that that is the kind of person that they were almost selecting for these trials rather than the person that is still taking their antidepressants and they need to taper off. Definitely some of the people were
Mm-hmm.
in that bucket, right? But I think like when I initially came across the trials, I was thinking like, well, yeah, like 100% of people were like that.
Mm-hmm.
And I don't know what percentage it actually ended up be, but they may actually be the minority. Um, which changes things too, because now it's like, well, some people had to taper and stop an antidepressant to be eligible for the trial. And how fast did they stop their antidepressant? And what were the washout periods? And were they experiencing withdrawal at the time of their first psychedelic assisted therapy session? These are all questions that, I personally don't have the answer to. Maybe the one of the researchers has more insight, but
Yeah.
yeah, it may affect outcomes in some way. Yeah.
And it just kind of ended up this way, but that actually perfectly segues into kind of the next topic that I wanted to address was
Yeah.
this article that came out again that shows where the medical literature, and from what I understand for quite some time, has more or less debunked or cast shadow a doubt upon this theory that serotonin levels have anything to do with depression.
That's right. That's right. So I think a lot of people that have been paying attention have known that low serotonin equals depression is a pretty broken
Mm-hmm.
hypothesis for a long period of time. But it's really common amongst the general population. You ask someone, why are you taking your antidepressant? Because I have low serotonin and because this drug increases serotonin. So the idea that depression is etiologically related to low serotonin levels seems just kind of faulty, or bunk. I don't know if that necessarily means that antidepressants. It's interesting because antidepressants are neuromodulating types of substances. Yeah,
Mm-hmm.
they block the serotonin reuptake pump, but that's not how we think that they help people. And I think that's just it right there. It's like if depression was a result of low serotonin and you gave an SSRI that increased serotonin, people should feel not depressed within a period of hours.
Yeah.
Yet it takes weeks to
Yeah.
months. So
Yeah.
obviously it's not related
Yeah.
to just
Yeah.
increasing serotonin. It's much like it's got to be more complicated than that. So I think it's fair to say antidepressants are serotonin neuromodulating agents. And serotonin as a neurotransmitter is a neurotransmitter that is implicated with regulation of mood, along with all sorts of other physiological processes. Right? So it doesn't necessarily negate that an antidepressant couldn't be helpful for somebody, but it really does kind of call into question, well, geez, well, that was the rationale. Like that's what we were told that these drugs did. So now it kind of like opens the question again. It's like, well, and the question's been open. It's like, what exactly are these antidepressants doing? And by the same token, what exactly are psychedelics doing? Because they're serotonergic substances that increase serotonin signaling. Right? They don't increase serotonin, at least psilocybin or LSD. MDMA does release serotonin. Right. So it's like, okay, serotonin, it's still very fair game to think there's something to serotonin neuromodulating drugs and mental health or mood or anxiety. Like that all seems very, very fair game still. But it just seems that the putting funding, research efforts, educating the public that depression etiologically as a result of low serotonin is just a load of what, and it just needs to die and be tossed out already and move on to some ideas that are more plausible that we can test and start telling people a closer truth about their serotonin modulating drugs. Yeah.
Well, in the article I read in Psychology Today, at the very end of the article, it just raised, it didn't make any assumptions or conclusions either way, but possibly some ethical implications here, that if you're a doctor and you understand, and maybe it's not necessarily in the prescribing of the antidepressants, but describing to the patient that, oh, this is a, serotonin, it helps raise your serotonin. This is all due to a chemical imbalance. Now, there might be some ethical implications past this point if a doctor knowingly describes that to the patient, like as the mechanism as to why they're prescribing the antidepressants. Again, I'm no medical ethics expert by any stretch of the imagination, but the article did raise it. You have any thoughts on that?
Yeah, I think always we should be giving our patients, our clients, the most accurate information that we can. I also feel that information changes.
Yeah.
That's the beauty of science, is that it's not static. It doesn't just rest on its laurels. Like if you test something and it doesn't work, that can be tossed out and you can try again. So, in psychiatry, we've kind of known that the low serotonin hypothesis has some big holes in it for a very long time, but over half of antidepressants are prescribed by general practitioners or family medicine doctors. And they may not be on the cutting edge of what the new theory is. So, going forward, right, if the media changes its tune and all the medical institutions change their tune, and there's a new standard as far as like what to tell people about how antidepressants are working, and you're still using the old standard, that does seem negligent to me.
Yes.
But you've been using what was the standard until this point, and some new information comes out, and then you change. It's sort of like, well, but to me, more than like what I wish people would say about their antidepressant when they're counseling them, rather than mechanistically, because mechanistically, it's the brain. Like we don't know how consciousness works. So how are we going to know where the drug that modulates consciousness works? Like how are we going to accurately, like I say, oh, it's a serotonin neuromodulating drug. Oh, it's closer to the truth, but it's still not like the mechanism of the antidepressant, right? But really what I wish doctors said something more like, hey, using these antidepressants, could be helpful for you, but it's going to be a commitment. You're going to have to take this medication for some period of weeks to months just to see if it works for you. There might be some side effects during that period of time that come up. And if it does work for you, I'm going to want to continue on that drug for at least 6 months, but probably more like 9 to 12 months. And at that point, we might be able to reevaluate things and see if you're ready to taper off of it. But oftentimes by that period of time, there is some level of physical dependence, and tapering can become a challenge for people. So I think a lot of folks that I meet are kind of like, I was having a really hard time in my life for whatever reason. I was having trouble at my work. I was having trouble at home in my relationship. I was still dealing with some trauma and issues from my childhood, and things just got really bad. And I went to the doctor and I kind of broke down. I just kind of cried and said, things are really bad right now. And they say, hey, here's a prescription that can help make things better. And that's really about all they were told about
Yeah.
it. And to me, that seems way more unethical, right? Than sort of a patient
Yeah.
coming in and being like, okay, so this is your antidepressant. We think it works by correcting a chemical. I mean, at least that doctor is attempting to explain something about it, right?
Yes.
Instead of just kind of like, oh, you're a little tearful in my office, or, you're having a rough patch here, take this type of thing. And then it's 6 months later, a year later, 10 years later, and they're not feeling all that more better, but they feel stuck with it and can't really taper off of it. I mean,
Yeah.
that inherently is what bugs me the most about
Yeah.
antidepressants rather than, thinking of it as a chemical imbalance or, yeah.
Yeah, to me, and this is just me. If I were a doctor and I had this information, I would just tell people, look, we once thought this was the theory of how these things worked and why depression is. There's information showing that might not necessarily be true at all. But look, these are antidepressants that have been shown to help quite a few people. This is an option for you, but you got to know there are some side effects. It could be hard to come off, right? But then I'd back it up with, hey, but if you wait another 2 years, these psychedelics might be able to help you as well. And I can't help but think of the timing of this and just the synchronicity of it. But I think at the end of the day, this is probably going to push a lot of people into psychedelic therapy once it's widely available. What are your thoughts on that?
I do. I mean, just logically, just think, I mean, it's going to take a while and we'll
Mm-hmm.
see. And it is still early days for psychedelic research.
Mm-hmm.
It's incredibly positive what's come out so far, but the trials are small, the populations are limited, et cetera. But I'm kind of thinking of it just like comparing these. Okay, you've got antidepressants as the first line treatment options, the recommendations for major depression, generalized anxiety, PTSD, OCD, like the list kind of goes on and on, just first line treatments. And what are the characteristics of those things? Takes a while to work. There's a commitment to using the drug for months
Mm-hmm.
to potentially years. There's a physical dependence and difficulty stopping it. There's a potential for chronic toxicities versus a psychedelic where it's kind of like, all right, if it works, it's probably going to work rapidly.
Mm-hmm.
We're talking about intermittent use here, so there is no physical dependence and or risk of chronic toxicities. So and the antidepressants can make psychedelics more difficult to use safely or effectively. So to
Mm-hmm.
me, the sort of like, 20 years from now, 10 years from now, I really hope that psychedelics do get approved, that the efficacy and safety of them continue to be substantiated, and that the treatment guidelines just flip on their head and say, hey, it makes no sense to use this drug that is a real commitment,
Mm-hmm.
a chronic therapy for at least a year that could actually interfere or diminish the potential for other treatments to work if this one doesn't. It kind of seems like, well, the first thing you would try is the rapid acting thing that could
Yeah.
potentially make you feel a heck of a lot better.
Mm-hmm.
Right. And then you would try the antidepressant.
Yeah.
And this is, all assuming that the data shows that everything is kind of mutually exclusive, where I think particularly for psilocybin, we are going to sort of find that maybe there is a dose that works for people taking antidepressants,
Mm.
maybe I don't know. All right, like
Yeah.
maybe
Yeah. Yeah.
we have to sort of wait and see. I mean, it's like an assumption, I think, that these things will never mix clinically when they're really out there and approved. Yeah.
And this kind of goes back to what we were, again, everybody, we were briefly talking before this, but a lot of people who come to these on a spiritual level, the entheogen psychedelics, a lot of them, for lack of a better term, have been beat up by the pharmaceuticals, right? And like their ultimate aim and objective is to actually get off of these pharmaceuticals and taking pills every day. But there's also, and I say this all the time, there's a contingency of people who have just become in that's their comfort zone, right? And so, and maybe it's a placebo that we're seeing that just this everyday kind of regimen. of taking these types of substances is really what's helping them on a daily basis kind of feel, I guess, a lot better.
Yeah. Well, I think it kind of comes down to, yeah, what to do with their medications. It's
Mm-hmm.
like, do they like their medications?
Yeah.
Do they help them? Is there
Mm-hmm.
a side effect burden? Are they
Mm-hmm.
coming to psychedelics because they see it as an alternative treatment for their mental health? Or are they coming to psychedelics because they read about the mystical experience and just
Mm-hmm.
wanted to have that experience? And it wasn't actually till they applied to a retreat center that the screening said, "Oh, your medications are a problem."
Yeah.
And they're like, "Oh,
Yeah.
I wasn't even thinking about that. I didn't
Yeah.
even know that." Right. So,
Yeah.
so yeah, as far as like what to do, I mean, it depends on what medications people are
Yeah.
taking, what kind of psychedelic or sacrament they want to using, and then what their sort of kind of goals and intentions
Yeah.
are with
Yeah.
the psychedelic and with their existing med regimen. Yeah.
Yeah. No, it's interesting to, and it's like, we have the medical scientific research, and I think all of these blend in together to varying degrees. But you got the medical scientific, then you have the spiritual side of these things, and I think at the end of the day, when we really get down to it, I think there's going to be like a blend between the two, where it's like the spiritual helps on the depression side, but then also there's this medical aspect of it too that also bleeds into the spiritual. Um, and it's that I get that because in ancient shamanism, really, especially in the South American tradition, my understanding, it's like the medicine man and the religious leader are kind of one and the same. You know what I mean? And so there's like this marriage of medicine and spirituality. And maybe when we talk about these mental health and stuff like that, maybe there is a healthy mix that we will find that optimizes the efficacy, both spiritually and medically, of these substances.
Yeah, absolutely. I mean, all the research out of Johns Hopkins is really
Mm-hmm.
focused, right, on highlighting
Yep.
the mystical experience and the
Yep.
spiritual nature of the psilocybin experience and how that spiritual experience is associated with positive outcomes in mental illness. And so that's just kind of, to me, I'm not really thinking that, well, psychedelics are so dangerous that they should only be used medically, or,
Mm-hmm.
oh my gosh, like those corporate medical people should never have psychedelics in
Yeah,
their
yeah,
hands, and it
yeah.
really should be in the hands of religious leaders,
Mm-hmm.
or
Yeah.
yeah, okay, it's just decriminalize nature, give them back to the people, right? So there's a lot of different voices out there, and I tend to agree with you that there may not really be a separation
Yeah.
between spiritual healing
Yeah.
and healing of mental illness. I think there's a lot of spiritual sickness out there in the world. And I think that psychedelics might accurately be conceived of as spiritual kinds of medicines. But I believe that different containers are going to
Mm-hmm.
serve different people
Yes.
differently,
Yes.
right?
Yes.
So you've
Yes.
got severe OCD, you've been suicidal for a long time, you're taking some medication that could conflict with it. I'm kind of thinking that, yeah, the setting of professionals that are equipped to deal with suicidality, that have action plans in place, that can provide you medical oversight and monitoring while you're tapering and beginning to use
Yes.
psychedelics, is
Yes.
probably the way for you to
Key.
go,
Yeah.
right? Versus I'm taking some small amount of an anxiety medication. It was
Mhm.
never severe. It was mild overall. I have no problem holding this for a little while. And, I'm a Buddhist and there's a Buddhist retreat coming up,
Yeah.
right? Like
Yeah.
there's a match between
Hmm.
people's severity of their issues and their spiritual beliefs too.
That's right.
Different centers, one of them, it's all about having the chakras, and that's how they operate. It's their
Mhm.
philosophy is from chakra. Some of it is from yoga, some of it is maybe secular, right? And different things are going to attract different people. So, yeah, there's not really a huge separation between treatment of mental health and spiritual healing, perhaps,
Yeah.
but it's important to have a variety of containers out there
Yep.
with different degrees
Yep.
of medical safeguards
Yes.
depending on who the person is. And this is always one of the things I tell, whether you're a psychedelic therapist, a facilitator, a retreat center, is you got to think about, who do I want to serve and who am I
That's right.
really qualified to serve? Like, whose
That's right.
emotional process could I support all the way through? Right. And if you're, a religious center and your goals are not necessarily to intensely support people through really difficult emotional processes around mental health related things, then, regardless of whether the drug's a contraindication or the condition's a contraindication or not, you should be thinking, well, our screening criteria, that person is excluded from who we are able to safely shepherd through this kind of process or experience. So it's just an honest reflection on what your skill sets are and who you really could help. And narrowing your practice down to that.
I've gone through a metamorphosis since I entered this space. So when I first got into this, I was really into the research. And I'll tell you what was funny is that when I started reading the research and then I saw, oh, they're saying the primary religious mystical experience is really kind of this one of the main drivers in positive change. That really jived with me in my previous mystical experiences. Or I was like, yeah, I jive with that, but I was still heavily involved in the research. Then I went to my first sacred ceremony and it was incredible. And from this day now, that's how I identify with these substances, right? It's a spiritual. And then I went on this whole like wanting to hear you have train of this is the only way to do it. The medical people have no idea what they're doing. These are ancient, modalities that they'll never get. But now I've come back around to kind of realize what I said earlier is that really I did realize this whole time that there's a whole population of people in this world that will only feel safe and comfortable inside of a medical institution with a medically trained individual supervising them. And they deserve to have access and they deserve to have healing just as much as the next person, right? But again, I think it's really a mixed bag. And there's some people probably in between that would be okay in either setting, but I do feel like both camps deserve to have that set and setting where they feel most comfortable, right? So that's why within TheoConnect, my original idea was to be mostly on the spiritual end, but I've now come to the hard conclusion that we need to have both the medical, scientific, and if we're going to maximize this for people across the spectrum, we need to have both ends of the spectrum represented, right? Because here's the deal is that maybe these religious practitioners know some very intricate stuff about set and setting that the doctors could use, but the doctors obviously know a lot about the safety and the screening and stuff that these religious practitioners can use. So I want to create a platform where we can come and share information and be cordial with one another, just for the ultimate purpose of maximizing this for the population,
Right.
Because there's people on both ends of the spectrum, very polarized on both ends, right? But I'm kind of like with you. I think that there's a lot of overlapping ground that a lot of people aren't seeing yet, that we could do some collaboration here, and ultimately everybody's going to benefit.
Yeah. Well, it's gonna be really interesting to see what happens with the kind of rollout of religious and spiritual use, or more widespread spiritual or religious use, and kind of what is required.
That's right.
Does the church need a medical director? Arguably, maybe.
That's the question. It seems like like with Soul Quest, it's like we're counting points against your religious claims because you have like doctors and facilities and stuff like that. But in the same breath, the DEA also would say that that's probably required to be safe, right? And we know the UDV and Santo Daime, both of them had doctors involved and had screening processes and stuff like that. So it'll be interesting. There's some irons in the fire on this religious end with litigation and stuff. So it'll be interesting moving forward to see how that comes out. And hopefully at the end of the day, we just have some more exact standards that religious practitioners can grab onto to try to, be compliant as possible and to be as safe as possible, right? I mean, ultimately, I hope that's what comes out of this, is that people are able to more safely engage in the spiritual side of it, if that's what they choose to do.
Yeah. Exactly.
Yeah.
I mean, as a pharmacist, your life is actually really simple. It's like if drugs can be safe, that's your number one priority. If they can be effective, that's your number two priority.
Yeah.
If you can make it cost effective and save some money, that's down to like number three, right? But really, it's about safety and efficacy, and exactly like just keeping people safe. And
Yeah.
The good part about psychedelics is that they are pretty safe. They are pretty safe substances. Like there are ways that you can get in trouble with them. There are some drug
Mm-hmm.
combinations out there that probably increase risks, but
Mm-hmm.
by and large, the observational data suggests that the average person in the adult population can safely use a psychedelic.
Yeah.
Um,
Sweet.
so we picked a
Well,
good class.
yeah. Well, I guess we'll kind of wrap it up. But I just wanted to say a few things to everybody. This Dr. Ben Malcolm, the Spirit Pharmacist, he has a website. I will drop a link. Working with a lot of these religious practitioners, when people come in on medications, I tell them, one, see if they can work possibly with their doctor to wean off if that's what needs to be done. But two, if they can't, they sure can call the Spirit Pharmacist or set up a consultation with him, and he can outline whatever risk might be associated with whatever combination. But beyond that, for facilitators, people who are planning on dispensing and serving these types of entheogens, the Spirit Pharmacist has a great set of courses that can help keep you up to par with kind of the latest as far as scientific knowledge and safety data related to these. And so, highly recommended. And I'll let you speak on it for a second, Ben, before we get off here.
Sure. So there's a number of things you could do, right? You can join my email list, which I
Okay.
send like a research update every month. I go through and pick somewhere between 6 and 8 studies. I do a lit search and kind of send you a summary of that. Also got some kind of just free resources. I've got a drug interaction and pharmacology guide that I actually put together with Tendava retreats on 5-MeO DMT. I've got an antidepressant and psychedelic drug interaction and tapering guide. So it's not only about just the drug interactions, but it's also how to taper your antidepressant and then like a monitoring tool. The blog on my website has a lot of other kind of just resources, informational types of things. Like Greg was mentioning, I do consulting, right? So people want a risk benefit analysis of the medications, supplements they're taking, their medical conditions, or whatever psychedelic that they're interested in. That's like one thing I do. Another thing is the courses that Greg mentioned. And the third thing is a combination of one and two. I have a member resource and support program. So instead of maybe accessing a course on its own, you can access a library of courses and webinars that I've put together, as well as some more specific drug information guides about classes of psychiatric medications and how they interface with psychedelics. Offer email-based question and answer through the member program. Right. So maybe you're a facilitator or retreat center, an organization, and you've got a screening process in place, but every now and again, you get somebody on medications or with other types of conditions you're not familiar with, and you'd like to kind of like consult with someone or outsource that question. That's a great use of the member program. Then I also offer discounted one-on-one consulting through the member program. So sometimes, for example, the organization, the retreat center, may ask the email Q&A, and the answer is it depends, and it would be really helpful to talk with this person to figure out what they want to do and make a plan from there. And at that point, the organization or retreat center can set their client or applicant up with a reduced consultation. So it might have been a lot for
Yeah.
just the last few minutes here, but
Yeah.
basically, I believe that psychedelics should be available in a variety of safe and supported kinds of
Right.
settings. So I'm working with individuals, therapists, doctors, retreat centers, organizations, whoever is interested in developing a practice, or maybe you're just a person on your own healing journey that wants follow up and to be able to ask psychopharm related questions. The member program, it definitely offers the best of me at
Mhm.
the best sort of like value, but people can do consults or get courses separately as well.
Awesome.
Yeah.
Yeah, Ben, thank you very much for your work, man. I mean, the thing is that people are engaging in these things at all different levels of the spectrum, right? And at the end of the day, we just want people to be safe and to get the best out of it that they can. And so, I can speak from the legal field here. Like, we really appreciate the work that you're doing, and I do plan on checking back in with you periodically, and yeah, working together just to try to make this a better space all around.
Yeah. And vice versa, Greg. Like we definitely need
Okay.
people fighting the litigation or like legal side of this because there's a lot of uphill work to do there, my friend.
Yeah, and I could go do a whole podcast on this, but I do see the tide turning, right? I kind of see the tide turning. And so that to me, that says, well, let's just push harder, you know, because hopefully one day, you know, my goal is that people will be able to safely engage in these without any fear of repercussion or, you know, consequence from the law, you know, that people again can kind of take their healing into their own hands to a certain degree without having to worry about, am I going to get arrested? Is this 100% legal? You know, that people can take that route and not have to worry about that. So, but we appreciate it, Ben, and thank you for
Yeah.
your kind words. And everybody, I will put a link to all of Ben's stuff into the description here. Highly recommended, and we will have him back. Thank you, Ben.
Thank you so much for having me, Greg. It's been a wonderful pleasure chatting with you.
Yeah, man, you too.